So broadband click stimulus is given to one ear with masking of the opposite ear. Okay. Now the waves are produced, and what all things you have to specifically look into the waves for assessment of any disease or hearing levels. Okay. So the wave pattern, pathologies in the waveform. So one thing is the amplitude, and the second thing we have to look is the absolute latency. And this absolute latency is compared between two ears, between the right and left ear. And in the case of wave 5, this absolute latency should be, or the difference between the two ears should not be more than 0.4 millisecond between the two ears. Okay. So, and the third thing we have to look is an interwave interval. Between which all waves? Between 1 and 3, then between 3 and 5, and also between 1 and 5. Okay, so the amplitude, absolute latency and interwave interval are the three things you have to specifically look into in the wave pattern. The next important thing is uses of BERA. The first thing is that we can differentiate between cochlear and retrocochlear. So cochlear is within the cochlea, retrocochlear is beyond in the central acoustic pathway. So whether the lesion is in the cochlear or in the retrocochlear area, we can very well differentiate by doing a BERA. Okay, so the first thing is to differentiate between cochlear from retrocochlear lesions. So in the differential diagnosis of cochlear and retrocochlear lesions, BERA helps a lot. It is usually a screening tool, and if after doing a BERA you get any of this, that is either an absent ABR of the affected ear or the involved ear, or absolute latency of wave 5 is prolonged, or compared to the two ear, interaural difference is prolonged in case of 1 to 5 interpeak difference, or wave 5 latency. In these cases, this is an indication for doing a gadolinium enhanced MRI. MRI scan. Okay. So after doing a BERA, if you get any of this, go for a gadolinium enhanced MRI scan, and in that case, finding out the lesion, the specificity is 90%, and you come to a sensitivity of around 70 to 90%. Okay, so that shows the usefulness of BERA in case of finding out very early lesions in the retrocochlear pathway. The second is newborn hearing screening test. This can be used as a screening test for hearing loss in newborn. So now the new regime is universal screening. So universal screening in all newborns, whether they are high risk or normal, regardless of high risk or the normal birth, this screening of hearing is done in all newborn using autoacoustic emissions. And ideally, what we are doing in a universal screening is that we do autoacoustic emission, and if it is we get a pass, then okay. If we get a fail, we repeat it after 1 month along with the immunization program, and again we get a fail, refer the patient for a BERA. And by doing BERA, we get a confirmation of hearing loss. That's the early detection of hearing loss can be done in children. Auditory neuropathy or nerve conductive disorders. In auditory neuropathy, the peripheral system will be normal, so that the child, the OA will be get a pass, but ABR will be abnormal. So it is better to do a confirmatory ABR in all cases of high risk children also. So second is a newborn hearing screening test. The next use is intraoperative monitoring of tumors, especially CP angle tumors like in vestibular schwannoma or acoustic neuroma. So we can do an early identification of the changes in the electrophysiological status of peripheral as well as central nervous system while doing the surgery. Like CP angle tumors, then vascular decompression of trigeminal neuralgia, then vestibular nerve section in case of intractable vertigo, then facial nerve decompression, along with facial nerve monitoring, the monitoring of the 8th nerve can also be done. Endolymphatic sac decompression in case of Meniere's disease and also brainstem tumor resection. In all these cases, intraoperative monitoring of the 8th nerve can be done by using BERA. And the next is for monitoring and understanding of tinnitus. Okay. This is beyond the usual advantages or uses of BERA. Okay, monitoring and understanding tinnitus. Another role is in prognostication in the case of coma patient. How is it? Of coma patient. Several studies show that if the Glasgow coma scale is 3 or below with an abnormal ABR, there is high probability of that patient dying. Okay, so Glasgow coma scale 3 or below with an abnormal ABR, chance of death is very high. Next is used as a biomarker in bipolar disorder type 1. The abnormal wave pattern can be used as a biomarker in bipolar disorder type 1. And also you know that wave 1 corresponds to the distal part of 8th nerve. So it gives a real-time information regarding the blood flow to the cochlea. And also the wave 2, you know, it is on the proximal part of auditory nerve. So wave 1 to 3 and also 1 to 3 interpeak interval can be monitored for during surgeries of the 8th nerve. So these are some of the uses or the main uses of BERA, and mainly in differentiate between cochlear and retrocochlear pathology, vestibular schwannomas, and also I already told you the indications for doing an MRA, gadolinium enhanced MRA in case of abnormal BERA waves. And newborn hearing screening, this is also a gold standard in the early diagnosis of neonatal hearing loss. And there are some contraindications for doing this BERA. And what are the contraindications and also what are the limitations? Coming to the contraindications and also limitation. There is no need to do a BERA in patients who undergo traditional standard audiometry. This BERA needs specialized equipments, sedation is needed. So if the patient can undergo other traditional standard audiometry procedures, there is no need of going for a brainstem evoked response audiometry. And also, I already told you this needs sedation, or in very apprehensive or in children, sometimes general anesthesia will be needed. So if there is an upper airway obstruction or central respiratory depression, heart failure, renal failure, epilepsy, etc., Phenobarbital or hydroxyzine hydrochloride should not be used as a sedating agent. That is important. Then this BERA is mainly for high frequency sounds. This works mostly on 2000 to 4000 Hz. So in lower frequency, this application is very less. And also there is no information on the auditory system above the level of brainstem. I already told you at the cortical level. At the auditory center at the cortex, we will not get any information. So that is also a limitation of BERA. But in cases of retrocochlear lesions in early acoustic neuroma, multiple sclerosis or an auditory nerve dysfunction, in all these cases this BERA is an excellent tool. Now you can see how a BERA is done in a child. In ABR, electrode placement is important. White is a vertex electrode or the high forehead. Yellow is the ground electrode kept low forehead. Color on the right side and the blue is on the left side. And NuPrep is the commonly used skin preparation solution. This skin has to be cleaned thoroughly before keeping the electrode. Otherwise, the chance of impedance, the resistance will be very high and it can alter your test result. So clean the area thoroughly and keep the electrodes. We can watch the rate of impedance or the level of impedance in the machine. See here, the high colored black area, ideally it should be in that high black area. And in this case the impedance is very high. So again the electrode has to be removed and reinserted after thorough cleaning of the skin. Now the impedance level is comparatively low. And the insert earphones are kept in infants like this. Again blue on the left and red on the right side. And the click stimulus is given. And this one is the ABR test screen. And you can split your screen to left and to right. And here we give a 70 dB. We can select the stimulus intensity. We are giving a 70 dB click stimulus and for air conduction. First is air conduction is tested. And on giving start, on giving the stimulus, the wave pattern will appear. Here you see this is post-auricular muscle artifacts are there. That is why it is coming like this. In that case, the adequate sedation should be given and the test should be repeated. This is on right side again, a click stimulus for air conduction. See, this is without artifacts. This is the usual pattern. If after giving the 70 dB, if hearing normally, then it can be reduced to 50, 25 like that. Or if the child is not hearing on 70 dB, the intensity has to be increased. So the waves after giving multiple click sounds for air conduction, test for bone conduction also. And after that, the wave pattern has to be reproduced. Right is red color always, also in PTA also. Here you can see the reproduced wave pattern which is normal in this case.